Good morning, good afternoon, everybody, and welcome to the IAPB Learn IAPB webinar on retinopathy of prematurity, or RoP, as we'll most likely to refer to it today. My name is Simon Day, and I'm the IAPB Program Coordinator for IAPB Africa, and I'll be chairing this webinar today. IAPB Learn webinars have been arranged to encourage our IAPB members to connect and learn on a range of IAPB, I beg your pardon, of eye health areas. I'd like to say that we have a really super number of 90 people who've registered for this webinar. So hats off again. Africa always seems to reach super high numbers when it comes to registration. We already have 30 attendees and that number's climbing nicely. So thank you to everybody for having registered. It's always great to have you online, and it's always super to have a great representation in Africa. Before we kick off, I'll just do a bit of housekeeping. So this webinar is scheduled to be an hour. So that's probably 45 minutes of presentations, and at the end we'll leave some time for Q&A. We'll have 3 presentations, and we like these sessions to be participatory. So if you have any questions, please type them into the chat box. You'll see a chat section on the right-hand side of your GoToMeeting window. And if you type them there, we will collect those questions and we will pose them to the presenters at the end of the 3 presentations. Right, so moving on to the webinar. A few introductions. As I said, I'm Simon Day from IAPB Africa. And our 3 presenters today, first off, we have Professor Claire Gilbert, Professor of International Eye Health at the International Centre for Eye Health at the London School of Hygiene and Tropical Medicine in the United Kingdom. We have Linda Visser, Head of Ophthalmology at the University of KwaZulu-Natal in Durban, South Africa. And we have Sarah Sitati at the Savatia Eye Hospital, Department of Pediatric Ophthalmology, Wodonga, Kenya. Now, as you all know, the theme of this IAPB Learn webinar is retinopathy of prematurity, or RoP. Now, RoP was the commonest cause of irreversible blindness in children in the United States and Western Europe in the 1940s. This so-called first epidemic came to an end when oxygen administration was better managed. However, RoP is now an important cause of blindness in children in the upper and lower middle-income countries, particularly in Latin America and Asia. Over 30,000 infants born preterm are becoming blind from RoP every year. This so-called third epidemic of RoP blindness is being driven by expanding neonatal intensive care, which is increasing survival, suboptimal quality of care, which increases exposure to risk factors, and lack of services to screen and treat the 5 to 15% of preterm babies who develop the sight-threatening stages of RoP. RoP is now emerging as a threat in sub-Saharan African countries as neonatal care expands. In this webinar, Professor Claire Gilbert will describe the clinical features, risk factors, natural history, and strategies for the control of visual loss from RoP, as well as factors which promote high coverage of screening and treatment. The webinar will also include presentations from the other 2 ophthalmologists, which I've mentioned, who are in Africa and are actively involved in RoP. So at this point, I will hand over to Claire and we'll make you the presenter. Everybody should be able to view your presentation, which is due to come on screen any minute now.
Well, good morning or good afternoon, everybody, and thank you for joining the webinar. In this presentation, I'm going to give you an update on RoP as a cause of blindness in children, and just explain again why it's becoming such an important cause of blindness in lower and middle income countries, which is called the third epidemic. And then I will briefly outline some of the public health approaches for control. In the year 2010, a meta-analysis was done of a very large number of studies to estimate the number of preterm infants who were becoming blind or visually impaired from RoP in the year 2010. And as Simon already mentioned, the number is over 32,000 children every year. And this world map shows where the the numbers, or a schematic representation of the numbers of preterm babies who are surviving, which is the total size of the blue circles. And then the blind is the dark wedge and the vision impaired is the paler wedge. Now, what you can immediately see from this is that RoP is now causing blindness in children in all regions of the world, but particularly in the very large populations of East and Southeast Asia and the Pacific. But it is also an emerging problem in the African continent and is likely to increase as neonatal care services expand in that region. This is what has happened in many, many other countries in Asia, and it's almost certainly going to happen in Africa as well. Blindness of early onset from whatever cause can have an enormous impact on children. It can lead to developmental delay. They're more likely to die. Many of them don't have access to schooling, and they are excluded and lack friendship and lack participation. Affected families can also suffer from quite severe anxiety and depression. It can lead to conflict and fighting over money and resources and marital breakdown. And some families are pushed into catastrophic health expenditure for raising the money to try and treat their children, and lost income through a caring role. So the impact on individuals and families and society is really considerable. So as outlined already, RoP is this next wave of blindness from RoP, or tsunami, I should say, is happening because of the expansion of neonatal intensive care, which governments are doing to try and drive down under 5 mortality rates. But unfortunately, the level of neonatal care is often suboptimal, and this puts a larger number of babies at risk. In addition, it's a new disease, if you like, in these regions, and so it's not been included in relevant training curricula for physicians, for ophthalmologists, and for nurses. And this has led to a lack of awareness and, importantly, in skills. Many countries lack the policies to enable control of known risk factors. For example, many delivery rooms do not have blenders, which means you can mix oxygen and air, and babies are either given just air or 100% oxygen, which can be very damaging to preterm babies. And also there is inadequate coverage of RoP screening and treatment. The Blenko paper I referred to before based their estimates on the estimates of the number of preterm babies worldwide, which is actually 15 million. This is data from the regions which I thought was relevant for this audience, particularly sub-Saharan Africa. But you'll see in these regions in Asia and sub-Saharan Africa, the number of babies who are blind and visually impaired from RoP is 50% of the global total. And this line here, the second row, is the important row because this is the babies who need to be screened each year, which in these 3 regions is over 400,000. And this is the number of 10,000 or so, 27,000 will need to be treated. So the numbers are large and are likely to increase. For those of you who are not familiar with retinopathy prematurity, it only affects preterm infants, and that's because preterm babies are not born with a completely mature retina, and in particular, the blood vessels are not fully formed. On the left, you'll see a full-term baby's eye, and you can see the retinal blood vessels reach the edge of the retina, which is called the ora serrata. In a preterm infant, the blood vessels have not reached the ora serrata, and you have this large area where there are no blood vessels. And it's changes in this part of the retina here which produces the growth factors which lead to RoP. So retinopathy of prematurity occurs at the junction between the vascular retina and the avascular retina, and you get abnormal proliferation of blood vessels at this boundary here. There's an international classification for RoP which describes 3 zones. I won't go into detail about this, but you'll see there two concentric circles centered on the optic nerve, and then a crescent around in the temporal retinal periphery. And it's useful to use this classification after examining a child because RoP in zone 1 has a worse prognosis than RoP in zone 2. There are 5 different stages. Stage 1 is when there is a line, a visible line between the vascular retina and the avascular retina. In stage 2, this becomes an elevated ridge, which you can see in the top slide in the middle. And in stage 3, you get abnormal proliferation of vessels. This sausage-like area of tissue here is abnormal proliferating blood vessels. In stage 4, you get partial detachment of the retina. So this upper part of the retina is out of focus because it's separated from the back of the eye. Stage 5 is total retinal detachment. And there's one other sign which is very important, which is called plus disease, when the retinal blood vessels are abnormally dilated and tortuous. This is a sign of very active disease. So the natural history, RoP is not present at birth, and it starts within the first few weeks after birth. It usually affects both eyes equally. In most babies who develop stage 1 or stage 2, the disease gets better on its own without any treatment. But in other babies, the stages can progress over the next 2 to 3 weeks, and it can progress to a stage where treatment is needed. And urgent treatment is essential. It has to be delivered within 48 hours of the diagnosis. So it's really quite different from diabetic retinopathy, where there is not that same level of urgency. If stage 4 or stage 5 develop, stage 4 can sometimes be treated and sometimes surgery is possible, but often the visual outcome is very poor. So the indications for treatment is when there's a mix of clinical signs, which means there's a 15% risk of progression to retinal detachment. And this is called type 1 RoP, which I think is a horrible name. So I'm going to call it vision-threatening RoP, which is how we talk about diabetic retinopathy. So the babies most at risk of sight-threatening RoP are increasingly premature and low birth weight babies, and those babies who receive suboptimal care, in particular poor oxygen management. Now the neonatal team really have a very difficult job, because if they give too much oxygen, then there's a risk of retinopathy of prematurity, and if they give too little, then there's a risk of brain damage or the baby might die. Other risk factors that are potentially modifiable include infection, poor weight gain, and blood transfusions. And in the bottom, you'll see photographs of neonatal intensive units in the same country. And on the right, you can see very, very high levels of care, certainly in terms of equipment. There's a lot of space between the babies. They have a nice cot. There's a stethoscope there. The baby's attached to a monitor. It's under a warmer. So very high quality care. But on the left, you can see, and I think everyone can see, that this is suboptimal care. And these babies who are sharing an incubator are being given 100% oxygen through this hood, and there's no evidence of any monitors on these babies. So the level of care varies enormously, and this means that the babies at risk also varies from unit to unit. So what can be done to prevent blindness from RoP? The first thing is to prevent preterm birth. This could be quite challenging and beyond the scope of this presentation. Improving the quality of neonatal care from immediately after birth is really very, very important. And ophthalmologists who are involved in RoP and screening really need to familiarize themselves with the risk factors so that when they go into neonatal units, they have some awareness of the level of care being provided. The next part is detection or screening and treatment of sight-threatening RoP. And importantly, all babies who are who developed any RoP, particularly those who are treated, need long-term follow-up because they are at much higher risk of developing complications like high myopia, which can even happen before they reach their first birthday. Screening for RoP, there are two ways that this can be done. The gold standard traditional way is by indirect ophthalmoscopy by an experienced ophthalmologist. And here you see Andrea Zinn in Brazil examining a preterm baby in a unit. And note she has a neonatal nurse with her to make sure that the baby is stable and not becoming distressed. The other way to screen is using wide field digital imaging, which can either be done by an ophthalmologist or a trained technician or a member of the neonatal team, as long as there's backup for an RoP expert to review and check the images. So which babies are screened depends on local evidence of the population of babies at risk, which essentially is the gestational age and the birth weight of babies who are developing the sight-threatening RoP. Screening must start within a few weeks of birth, and in India, they say by 30 days of life. For inpatients, the screening must be done in a neonatal unit because it has to be done on a very regular basis, and it's important that the first and subsequent examinations are done at the right time. Babies who are well enough to be discharged can be seen in an eye department or on the neonatal unit during follow-up. And the number of examinations needed ranges from just one. Some babies need 8 or even more examinations. And what is very important is the findings must be documented and communicated to the parents at each screening or episode or examination. Treatment, as I've said, needs to be urgent, and the gold standard way of treating is by laser to the peripheral avascular area of retina, and this needs a highly skilled ophthalmologist. It needs to be done in the unit if the baby is still an inpatient, and a neonatologist or anaesthetist must be in attendance to make sure the baby stays stable because this is a stressful procedure. Emerging treatments are with intraocular injection of anti-VEGF agents, but there is not yet evidence of the long-term systemic and ocular safety, so it's recommended that these are just used as rescue treatment when laser treatment is not possible. So what policies are needed for prevention? There need to be policies in place to give women threatening preterm delivery a course of antenatal steroids. This matures the lungs and reduces the risk of RoP. Blenders and saturation monitors must be available in all delivery rooms, and there needs to be equipment and systems in place to safely deliver and monitor oxygen. Many of the oxygen aspects are lacking in low and middle income countries. There need to be equipment and consumables for screening and for treatment. Ideally, control of RoP should be included in prevention of blindness plans and, importantly, in the job descriptions of those doing the screening and treatment, so time is allocated for these activities. Policy briefs can be a very important way of informing decision makers about what needs to be in place, and this is an example of a policy brief for USAID's Episcale program, and it talks all about RoP screening and treatment. National guidelines are also very important to support programs, and these should be developed engaging the Ministry of Health and professional groups and those with expertise in prevention and treatment of RoP, and the recommendations should use local evidence for prevention, for screening and treatment, and which babies should be followed up. Very importantly, there's a need to monitor RoP programs, and the importance of this to identify problems such as, are all eligible babies being examined? We know that up to 40% of babies who should have been screened are not screened in some settings. This means they may be leaving the unit and then subsequently getting RoP and losing their vision. It's a way of identifying problems and exploring what has happened so that corrective action can be taken. Online systems are ideal, but paper records work just as well as long as the data are used. Having protocols in place is very a good practice to promote good clinical care, and these can cover many different aspects of care from immediately after birth, such as delayed cord clamping and withholding oxygen until it's absolutely needed, for neonatal care, for screening so the nurses know how to prepare the baby, and for treatment, for example, how to monitor the baby during treatment. And these can be revised as new evidence becomes available. Partnership is very important, particularly teamwork within the neonatal unit, which recognises the vital role played by all staff, as well as by parents who can be important advocates for their child's health. And collaboration and coordination and communication between all these different groups of individuals is really incredibly important, both within the unit and at higher levels in the health system. So partnership at national level, ideally there should be a national multidisciplinary coordinating group to review and guide program development, implementation and scaling up, and importantly, representatives of the Ministry of Health responsible for newborn health, child health and eye care need to be key members of a national committee, as well as representatives from the National Prevention of Blindness Plan, from relevant professional bodies including nursing and obstetrics and gynecology, parents, NGOs and the UN agencies who have anything to do with eye care or with newborn children. Legislation and litigation have a role. Legislation has been implemented or introduced in several countries in Latin America, which mandates the examination of preterm infants, and this has really had a major impact on ministries of health improving coverage of services. And as we know, unfortunately, in some countries, litigation and lawsuits can also drive the process of change. So what are the impact of these different public health approaches? This is a very interesting study which shows that in 4 countries in Latin America, 95% of eligible babies were screened, and these 5 countries either had all 4 of these different aspects in place: government policies, national guidelines, legislation and monitoring systems, compared to these other countries where they only had 1 or 2, where only 35% of eligible babies were involved. So this really shows the importance of engaging government from the outset and having national systems in place. Leadership is very important for advocacy, and certainly in Argentina, we know that a group of neonatologists and ophthalmologists were absolutely instrumental in reversing RoP as a really major cause of blindness in that country. And policymakers and program planners need to know how the problem is now and how it's likely to get bigger in the future, and what's the impact on children and parents, and the economic impact. Why is this happening and what can be done, and is this effective? And we know that screening and treatment are highly effective, and what will it cost to control? There are a lot of agencies and players now interested in newborn health and neonatal survival, including UNICEF. DFID, preventing disability is very high on their agenda, and so preventing blindness in children will tick their boxes. USAID are supporting newborn care in a number of African countries through their EpiScale program, and the International Pediatric Ophthalmology and Strabismus Council are an excellent source of medical expertise around the world. And so our aim is to reduce blindness from RoP amongst preterm infants, and here you can see a very happy mother who was herself a neonatologist, and her baby has just been treated for RoP. Thank you.
Thank you, Claire, for this very comprehensive overview of RoP. And I think it really highlights the needs for RoP services from the earliest stages of a child's life. and how these services need to be integrated at all levels of the health system. Our next presenter is Linda Visser, Head of Department of Ophthalmology at the University of KwaZulu-Natal in Durban, South Africa. And Linda will be discussing, will be telling us of her experiences when setting up a national program for RoP in South Africa, including the challenges and successes. So thank you, and over to you, Linda.
Thank you very much, Simon, for the introduction. I've been asked to say something about setting up a national program for RoP and the challenges and successes that we had in this process. So, before you start out working on a program, you have to decide who are you going to involve. Is it going to be the National Department of Health policymakers or clinicians or the community? How do you want to structure your program? Is it going to be just in the unit or the district or nationally? What resources do you have, especially financing and human resources, to develop your program? How should you develop your guideline? Starting out with what is already there in the rest of the world and building on that. And then you must decide how you're going to monitor it, because it's no use trying to have a program and not monitor what you're doing. As per the WHO guideline development document, a guideline is any document that contains recommendations about health interventions, whether clinical, public health, or other. And they are intended to assist providers and recipients of healthcare and other stakeholders to make informed decisions, and they should always be free of bias and meet some public health need. So if you're going to draw up a guideline, which is an important part of your program, you need to start off by saying, well, it's probably going to take you 9 to 12 months to complete. You should work on what is already there by doing a systematic review of what evidence already exists. Have a few people included in your guideline committee who will meet on 3 or 4 occasions and develop the guideline as a draft. You need to have a review by date, because most guidelines are only relevant for a number of years, and then you need to review it. Practical points to remember: set your objective, make sure you have your target audience. It is not always easy to try and make one document for everyone concerned, for your policymakers, as well as your clinicians, as well as your managers. It might be better to have more than one document so that everyone knows what they have to do. But trying to have one single document for everyone is often difficult. Set a timeline, work on what you have, use resources from other countries, and then finally try and get some evidence from your own population. Do a bit of an audit before you start to know where you need to go towards. Finally, decide who your key experts are you're going to use in drawing up your guideline. It can be 3 or 4 people from your community. In the case of RoP, you'll probably need maybe 2 neonatologists and 2 ophthalmologists to work on it. These people will have the draft document drawn up. Then you can send it out to other external reviewers, and again, some pediatricians and some ophthalmologists, some people with maybe different views on the subject as well, just to get their input. And once you've had all the input and you've got a final document, it's important to try and get endorsement from various professional groups and then have this document published. So what was our context that we worked in at the time? Well, South Africa is an interesting country. It's more like a world in a country, where you have first and third world medicine. There's excellent private medical care in most of the cities. Unfortunately, only 20% of the population have access to the private medical care. There's also excellent academic and tertiary care within large centers, but there's a large rural population where medical care is not always that great. If you look at previous publications on the theme of RoP in South Africa, you'll find that between 1991 and 2006, there were 4 publications, all 4 from academic institutions, 2 from Gauteng province, which is the small province, highly populated province north in South Africa, and 2 from the Western Cape, which is also the highly developed part of South Africa. None were from the KwaZulu-Natal, which is the province on the east coast where I am from. So if you look at these publications, you'll find that they were all done at university hospitals. They were not large, small numbers were screened. The screening criteria was similar. The 1991 group had slightly more mature babies. The incidence of RoP ranged between 16 and about 30%, and the incidence of treatable RoP was quite variable between 1.6 and about 7%, probably because the definition of treatable disease was not always the same in all these studies. But overall, the problem didn't seem to be such a major problem up until 2006. In 2008, a needs assessment was performed in South Africa. At the time that the needs assessments were done in other parts of the world as well. Claire was involved in this, and they looked at 17 neonatal intensive care units in South Africa, 14 of which were in public sector and 3 in the private sector. And they were in the 3 provinces I've just mentioned of Gauteng, Western Cape, and KwaZulu-Natal. And in those 14 units, they found that there was quite a low incidence of treatable RoP, only between 1.6 and 2.9% at the time. And because of that, they felt that the competing demands and limited resources in the public sector in South Africa was precluding prioritizing prevention of RoP. However, around that time in 2008 in KwaZulu-Natal, we were specifically already seeing a major increase in the number of RoP cases, which had started in around 2004. And by 2008 had about doubled the number that we'd seen in 2004. And I felt the reason why we were seeing so many more cases in those years was because in 2004 there was a decision made by the provincial government to decentralize some of the neonatal care to smaller rural areas. So the larger premature babies were actually decanted to lower level care. And that was causing the rise in RoP, because in these lower level hospitals, the nursing staff did not know anything about RoP, and there were no screening. There was no screening taking place. We looked over the years of 2008 to 2015 at our numbers in KwaZulu-Natal. We had a large number of babies, close to 3,000 babies screened in that time, and found that we had an incidence of 35.6% of RoP of any type, with an incidence of 5.1% over the entire 8 years. However, interestingly, if you look at the graph for that time, you'll note that in the first 4 years between 2008 and 2011, there was a steep increase in the number of treatable RoP cases. And subsequently, in the 4 years thereafter, it was again declining. And we found that our mean gestational age in these babies when they had treatable disease was 28.5 weeks, of which the most mature was 32, so quite mature babies often. And in the non-treatable disease, 29.5 weeks was the mean gestational age. The mean birth weight for treatable babies was 1.16 kilograms, which up to 1,680 grams as the largest baby needing treatment, which is quite a mature and large baby. In the non-treatable disease, the average or the mean birth weight was 1,208 grams. In the first 4 months, we had a large number of babies of 1,400 grams or more that needed treatment, a total of 5 at 1,500, 2 at 1,600, and another 1 at 1,680 grams. Whereas between the years of 2015, there were only 2 babies of 1,500 grams, so much improvement after 2011. So basically the main reason for this increase in the first 4 years was the decentralization of neonatal care to the districts. And even though we as ophthalmologists would bring it to the attention of the neonatologists that we were seeing a lot more RoP, and we thought it was because of the decentralization of care and therefore poor awareness and poor screening, nothing really happened until in 2010 there was the first major litigation case against the pediatricians. As Claire was saying, that's often the thing that gives impetus towards change. And it was after this that the pediatricians decided that that we did need to change, and that the baby should not be decanted to lower level care. And there was a lot of discussion in our province between the neonatologists and ophthalmologists, and we drew up some guidelines for our own province in 2011. And subsequently, the numbers of RoP, treatable RoP, has decreased quite significantly. So where we in 2011 had an incidence of 7.8% treatable disease, it's now back to 3.5%, so more than halved the numbers. In 2012, the National Ophthalmological Society asked me to assist in drawing up our national guidelines for prevention, screening, and treatment of RoP, because not only KwaZulu-Natal, but other provinces were now also seeing the same problem. And we started drawing it up, and these were published in 2013. So what were our challenges at the time of drawing up our guidelines? Firstly, from a neonatologist perspective, there was a lot of talking about what the saturation levels should be set at. We finally decided on having 2 levels, 88 to 92% for infants who were less than 36 weeks mature, and 90 to 95% for infants after 36 weeks, or those with chronic lung disease. And this was chosen because at the time, the majority of published studies had been using these values. However, we did make a note that once the NeoProm results were to be published, we may have to change our levels, and we have subsequently done so in most neonatal units, where now the values of 90 to 95% are generally used. The second challenge was to have the pediatric ophthalmologist decide on what the upper limit for weight and gestational age would be best to use. We finally agreed on 32 weeks and a birth weight of 1,500 grams as the absolute criteria, so with or without any other oxygen usage or other risk factors, but that we would add babies between 1,500 grams and 2,000 grams under certain circumstances, specifically where additional oxygen or supplemental oxygen was used and it wasn't properly controlled and it wasn't blended. Because we had seen in our patients, up to patients with birth weight of 1,680 in our audit, that we had to treat these babies. So we decided it would be best to add the higher birth rate as a discretionary, birth weight as a discretionary factor. It does, however, compare quite well with those, the gestational age and birth weight of USA, UK, and India as well. We probably need to review our guidelines now, because it's 5 years since we published it, and we may be able to decrease the gestational age to 31 weeks, as has been done in the UK. We've also had challenges in the implementation. We still don't have a national database, and that needs to be set up in the next few years. And there's still a lack of resources in some of our facilities. Still a few neonatal units that don't have blenders. Saturation monitors, generally most have now. We still don't have indirect ophthalmoscopes in every neonatal unit where screening needs to be done. And we definitely don't have REC cameras. These are quite expensive. And we are short of ophthalmologists to go and screen in the various neonatal units. So even though we've taken big strides in improving our RoP screening, we still have some way to go. Thank you very much.
Thank you, Linda, for your presentation and for sharing with us your experiences and how you've had to tackle these real-world issues. I think one of the big highlights is the importance of comprehensive guidelines, which really result in improved and standardized services. Your point is also taken about resourcing where the need is there, but having to fight for the resources is an ongoing challenge. Our final presenter is Sarah Stitati of Kenya, and I must apologize. She's actually in the Department of Pediatric Ophthalmology at the Kenyatta National Hospital in Nairobi. And she'll be presenting on starting out the RoP program, the challenges and successes. So thank you, Sarah. Over to you.
So I'm going to be talking about the Kenyan experience with RoP and how the problem has emerged over the last 5 years. And I will start by painting a picture of what we had in the RoP scene 5 years ago in this country. The first thing was that survival rates of prematures were low. This has been shown in what Claire presented from the Blanco study and was confirmed by the Kenya Demographic and Health Survey of 2014. The second thing we had was that RoP was not considered a significant cause of childhood blindness compared to other diseases such as cataract. And this was shown in studies done in the schools for the blind in East Africa, where retinal blindness, including RoP blindness, were not found to be a significant cause of blindness in children. We also had scanty evidence on prevalence rates in the country. There was one study which was done by Wanjala et al. In Nairobi in 2007, which showed the prevalence rates were about 16.7, 16.8%, and comparable to countries in the developed world. But there were no other studies that had been published or done at this point. So later on, over the past 5 years, as we as ophthalmologists started to take a keener interest in RoP, we had more studies done. The first one I'm going to talk about, this is my study completed in 2016 in a rural government hospital in Kenya, which showed a very low prevalence of RoP, 3%. And this study was basically and high mortality rate of preterms. We had another study also completed at around the same time by Onyango et al. Completed in 2017, done in a private urban hospital in Nairobi. And this one showed a high prevalence of RoP of over 40%. And this hospital was characterized by low mortality rates. A third study done at the Aga Khan Hospital is still awaiting publication, also showed a high RoP rate of over 40%. So at this point, we basically made the conclusion that we had high prevalence in urban private hospitals because the premature babies were surviving more, and low prevalence in rural government hospitals where mortality was still high and neonatal systems were still undergoing development. Over the next few years, the main national hospital, which is Kenyatta, started screening for RoP regularly. We also received increasing requests from pediatricians all over the country to implement RoP screening in hospitals where we had ophthalmologists. We also formed the RoP working group. This was a group of ophthalmologists, both in the pediatric and retina specializations, together with neonatologists who came together to basically develop national guidelines for screening and treatment of RoP. And this initiative was supported by the College of Ophthalmology and was supported also by the Ministry of Health and other partners. So at this point, basically, we were focusing on private urban hospitals because this is where we saw a lot of RoP, and screening took off hospitals in the capital. But then about 2 years ago, we started seeing babies like this one presenting to pediatric ophthalmologists and to retina specialists. And these babies were coming with stage 5 RoP at the age of 4 to 5 months. And these were not coming from private hospitals, but they were coming from rural government hospitals, which were improving their neonatal care, but had no screening programs available for RoP. And so basically, these children were missed and came to us with blinding RoP. And so we realized that we needed to do more to curb this new epidemic that we were seeing. So the challenges that we are facing right now is that Not all ophthalmologists are well trained in screening and treatment of RoP, especially in government hospitals. This is because the hospital with the residency training program only began screening 3 to 4 years ago. So those who are newly graduating had some exposure to RoP screening, but not everyone has this training. We also had a problem with awareness among pediatricians and other clinicians about RoP or RoP screening. This included medical officers and interns working in neonatal units who are basically the doctors on the ground taking care of these babies. Another challenge that we have had, which is a global problem, is basically resources for training, for prevalence studies, and basically for equipment and infrastructural support for government hospitals, especially to for RoP. We, as the RoP Working Group, developed partnerships with the Ministry of Health, with the College of Ophthalmology of Eastern, Central, and Southern Africa, and with non-profit organizations, and more recently with the London School and the RoPNet program for Africa, which is helping us to develop our guidelines and basically roll out RoP screening in government hospitals. The progress that we have made so far is that we completed our national guidelines. This was based on the studies that had been done locally and whatever experience that we had screening over the past 5 years. And these were developed basically with the help of the Ministry of Health and the College of Ophthalmology in the region. We also, our partnership with the RoPNet is also going to assist us to roll out screening in government hospitals. We have picked a few to start out this program, and that is basically where we have seen blind babies coming from. And then hopefully we will be able to roll out to the rest of the country with time. We have also tried to do a lot of awareness in terms of publishing whatever work we have done, newspaper articles for awareness for parents and the general public, and presenting at every conference that we have had the opportunity to go to. The main lesson that we learned through this is that prevention of RoP blindness is a collaborative effort. We need to involve the pediatricians, the neonatal unit nurses, the ophthalmologists, and the parents. And once these 4 groups of people are involved, RoP blindness better, we can screen more babies and we can reduce our loss to follow-up once they're discharged from the neonatal units. I'd like to end my presentation by showing this picture, which is one of my favorite pictures. And these are mothers from a rural hospital in Kisumu, which is in the western part of Kenya, who presented to the clinic with their babies for RoP screening. These are mostly mothers with babies who had been discharged before they were screened, but informing them that their babies needed to have their eyes checked, brought them to the clinic on time, and they were very happy to be part of the RoP screening and prevent childhood blindness. So it can be done even in the rural areas. We should not feel discouraged that maybe the mothers will not show up. And if we work towards this, then we will be able to basically fight RoP blindness as it continues to emerge in Africa. Thank you.
Thank you, Sarah. Again, a really great presentation, and it seems to echo some of the issues that were raised in the previous presentations around awareness of RoP being quite poor, the need for guidelines, and also the lack of resources available to establish integrated RoP services. I think you touched on a really important point, which relates to RoP, but also eye health in general, which is that services come about through a collaborative effort. and that speaks also more broadly with regard to universal healthcare. We're coming to quite close to the end of our allotted time. However, we have had some questions in, so perhaps I will pose one question to each of our presenters, and then if we have more time, we'll move on. So starting from a question from Eugene Loshi to Claire. Claire, if you're available. The question is, can RoP be easily diagnosed without necessarily using sophisticated medical procedures? If yes, how?
The short answer to that is no, unfortunately. The outside of the eyes look entirely normal. The pupils have to be dilated, and the only way to examine the retina is with an indirect ophthalmoscope or with a camera. So a short answer.
Sure. Short answer is exactly what we need. Thank you. Next question for Linda from Andrew Odoriki. And how acceptable is it for pediatricians to screen if they're trained?
Well, if they are trained, anyone can do the screening. Anyone is trained. We've just found that it's quite difficult. It takes quite a while to try and train pediatricians to use the indirect ophthalmoscope. Even ophthalmologists take quite some time to learn to use indirect ophthalmoscopy. Using cameras, I suppose that's more easy to train someone to use the red cam or other cameras. Those are a lot more expensive though, but yes, a lot of places even use technicians to do the photography. So as long as you can learn how to interpret the photographs, I suppose you can have anyone doing the screening, anyone who's around. But indirect ophthalmoscopy is probably still the gold standard, and that is not that easy to be learned.
Can I quickly add something?
Please go ahead.
The imaging systems currently available are very expensive, but there are lots of groups working on this now. And I foresee in the next 5 years probably that there will be much more affordable cameras. It really does open the option for each unit to have a camera and then train a member of the neonatal team to take the images. This is being done in many places in Canada and in the UK. And then with a backup of an ophthalmologist to review the images. I think this is a way forward, particularly in places where ophthalmologists are in short supply or they're not willing to do this extra work.
Thank you, Claire. A question for Sarah from Daksha Patel. How are pediatricians, NICU nurses, and ophthalmologists trained to use RoP guidelines in their practice?
Okay, the most important thing is to involve them in the beginning when you're creating the national guidelines so that they're aware of the process and you have input from all the stakeholders. In Kenya, we did involve the neonatologists, ophthalmologists, and nurses in the development of the guidelines and also policyholders. After that, when you're rolling out the guidelines, at least you have a few people, key people in the community who are aware of them, and you need to define the roles of different cadres very well in the guidelines so that if a nurse wants to look up immediately what her role is in screening of RoP, she can be able to do so from the document. Another thing that can help is if you have posters which simplify the process, and this can be put up in the neonatal units, then it's something that everyone can glance at and it can give maybe criteria. Should be seen by the pathologist, or which ones to refer, or which ones need to be screened. That is also very helpful, just as a summary so that they know that these are the guidelines that we need to follow. Thank you.
Thank you, Sarah. I'm afraid, everybody, that we are out of time. There are a couple more questions, but I think we're going to have to wrap up now. And the questions really do show what kind of interest there is out there. So At this point, I would like to thank our presenters. I'd like to thank Claire, Linda, and Sarah for their really comprehensive presentations and responses to all of the questions. We really have been very fortunate to have all of them available for this presentation. I'd like to make a specific thank you to my colleague in London, Emma Foote. She arranges our IAPB webinars. So there's a lot of work that goes on behind the scenes. And right now, she is still behind the scenes and arranging all of the technical support. So Emma, to you, thank you kindly. I'd like to thank everybody who's participated. And by that, I mean our audience. We appreciate you all taking the time to be part of the IAPB Learn community. We hope that you've learned something from this webinar on RoP. And if there is more information that you'd like, please do drop us a line. And again, thank you for your enthusiasm. Having a record number of registered attendants really makes us look good. Right, just before I leave, I'd like to remind you that you'll be receiving a survey by email. It comes from the GoToMeeting email address. If you wouldn't mind taking a few short minutes to complete this, we really would appreciate your feedback. So thank you again to everybody, and we look forward to seeing you all at the future IAPB Learn webinars.